Harriette Van Spall, Associate Professor of Medicine from McMaster University, and I'm absolutely thrilled to have Professor Scott Solomon from Harvard Medical School, who is here to present his late-breaking clinical trial, DELIVER. Welcome, Scott.
Thank you, Harriette.
Why don't you tell us about the knowledge gap that DELIVER will close?
Well, first of all, as you know, there are about 64 million people living with heart failure worldwide, and about half of those people have heart failure with mildly reduced or preserved ejection fraction. We've been so successful in treating heart failure with reduced ejection fraction, but we've been less successful in treating heart failure with mildly reduced and preserved ejection fraction. So we're very excited with these new results in this trial. DELIVER was the largest trial ever done yet in heart failure with mildly reduced and preserved ejection fraction, and really serves to fill in some of the gaps. Even though we had data a year ago at the ESC from Emperor Preserve that was fabulous in reducing cardiovascular death and heart failure hospitalization, there are at least three groups of patients in which we really have less knowledge about, and these include patients who were recently hospitalized or started in hospital. They're patients with improved ejection fraction, that is those people who started with an LVEF under 40%, that is then improved to over 40%. And also Emperor Preserved, as you know, there was a question about attenuation of the treatment benefit at the highest part of the ejection fraction spectrum. And these are all answers that we hope to be able to answer with DELIVER.
Fantastic. And you know, the broader context is SGLT2 inhibitors have really changed the way heart failure care is delivered, and also given us armamentarium to reduce the incidence of heart failure. And this is a specific knowledge gap that no trial has ever tackled. So a first of a kind clinical trial that involves mildly reduced ejection fraction, improved ejection fraction in patients who are newly initiated following hospitalization. Tell us about the trial methods and the eligibility criteria.
Yeah, so we enrolled patients who had New York Heart Association class 2 to 4 heart failure, left ventricular ejection fraction over 40%, but that could include people who had previously had a lower ejection fraction so long as it had improved. Patients had to have elevation in natriuretic peptides, and they had to have evidence of structural heart disease as well. They could be enrolled either in the ambulatory setting, in hospital, or shortly after hospitalization. We randomized patients to dapagliflozin 10 milligrams or placebo. We ultimately randomized 6,263 patients. It was an event-driven trial, and we followed patients for a median of 2.3 years.
Right, and how many events were you hoping to accrue during that follow-up period?
About 1,100 events.
Okay.
Yeah.
And then tell us about the baseline characteristics of your patients.
Very characteristic of our heart failure with mildly reduced and preserved ejection fraction population. We had an average age of about 72, 44% were women. We had a mean ejection fraction of 54%. The mean GFR was 60. The majority, about 70% of patients, were New York Heart Association class 2. Patients were on the sort of typical medications that we see in this population, including diuretics. 70% were on loop diuretics. About 85% were on ACE inhibitors, ARBs, or sacubitril valsartan. 80% on beta blockers, and a very high percentage on mineralocorticoid receptor antagonists, 42%.
And what proportion of participants had improved ejection fraction?
18%, which is the first time that these patients have actually been allowed in a clinical trial in heart failure. They were excluded from all other trials.
And what proportion had mildly reduced ejection fraction?
About 70% had an EF that was below 60%, and probably about 40% had an EF that was between 40 and 50%.
Fantastic. So tell us the trial results. We haven't heard them before because you've yet to present them, so I get to hear them before anyone else.
Well, you do get to hear them before anyone else, and very exciting. We saw an 18% reduction in the overall treatment benefit for the primary composite endpoint, which was a composite of cardiovascular death and worsening heart failure. Worsening heart failure consisted of both heart failure hospitalization and an urgent heart failure visit. And we saw that in our patients overall. We saw that in patients with an EF that was over 60% and very consistent results across the ejection fraction spectrum. No evidence of heterogeneity or even a hint of attenuation as ejection fraction went up. So that was the primary result. We saw a 21% reduction in heart failure hospitalization and a 12% non-significant reduction in cardiovascular death. We saw a significant reduction in total heart failure events and cardiovascular deaths, not just the first, but the recurrent events. And we saw a 2.4 point improvement in the Kansas City Cardiomyopathy Questionnaire Total Symptom Score, a measure of symptom burden that was highly statistically significant. And no matter how you look at it, if you look at 5-point improvement, 10-point improvement, 15-point improvement, you're more likely to have that in the dapagliflozin arm than in the placebo arm.
Remarkable how the treatment effect was consistent with Emperor Preserved in that the size of effect was similar and the component outcomes were similar, the effect on the component outcomes. Yes. Did you have a large enough event rate for cardiovascular death that you could be certain as much as you can with regards to treatment effect on a component endpoint?
No, it's a very important question because cardiovascular death, as you know, is less common. The rate of cardiovascular death is about half in patients with heart failure with mildly reduced and preserved ejection fraction as they are in heart failure with reduced ejection fraction. In this trial, it was exactly half as it was in DAPA-HF. So we didn't have the power to answer that question. Now, you will see additional data when we pool together the DAPA-HF and DELIVER trial. You'll see additional data where we've pooled together in a meta-analysis Emperor Preserve and DELIVER. And there you can see that with more power, with more events, we really do believe there is an effect on cardiovascular death, but these trials are individually too small to show that.
Right, so in that pooled analysis, was there a significant treatment effect on the endpoint of cardiovascular death?
Yes, a very significant treatment effect across the spectrum with no hint of heterogeneity. In other words, the treatment effect was the same from the lowest EFs in DAPA-HF to the highest EFs in DELIVER. And that tells us that this is a therapy that probably does work similarly no matter where you are in the heart failure spectrum.
Right, and heart failure hospitalization has a tremendous burden on our healthcare system. So it's a very relevant endpoint to show a treatment effect in. Can you comment on effect on all-cause death?
Yeah, so interestingly, the hazard ratio for all-cause death was 0.94, and it was not statistically significant. Remember, these drugs don't have an effect on non-cardiovascular death. We also had a lot of COVID in this trial. We had close to 600 patients who were diagnosed with COVID during the course of DELIVER, 155 deaths that were ascribed to COVID during the course of DELIVER, and those are all non-cardiovascular deaths and not really modifiable by a therapy like this. And in fact, when we censor the patients at the time of COVID diagnosis, we even see a stronger effect for all-cause mortality because you get rid of all those COVID deaths. The other point I want to make is that we saw consistent results in the patients who were recently hospitalized, and we saw consistent results in that group of patients with heart failure with improved ejection fraction And we're very excited, of course, about that because this is a group of patients that we didn't have a lot of data for.
Can you comment on renal endpoints at all?
Yeah, so we didn't in Deliver collect renal endpoints in the way that many of the other trials did. So what we can say is that the renal adverse events were about similar in the two groups. We will be presenting more detailed data at the American Society of Nephrology about the GFR slopes, and we're excited to share some of those data as well, but we won't be presenting those at the ESC.
Right, so a lot of secondary publications and subgroup analyses, but the big take-home point is that dapagliflozin has a large treatment effect on the composite endpoint of heart failure events and cardiovascular death among patients with mildly reduced ejection fraction, preserved ejection fraction, and improved ejection fraction, with pooled estimates from two large trials showing that there is also a treatment effect on cardiovascular death among SGLT2 inhibitors. Thank you so much for joining me today, Scott. I'm so excited about your presentation, and I can't wait to see you on the big stage.
Real pleasure, Harriette.